Thank you, everyone, for joining us today. My name is Tara Britton. I'm the Director of Public Policy at the Center for Community Solutions. Over the last few weeks and for the next several weeks, we have been working with Advocates for Ohio's Future to host weekly Friday webinars examining different policy areas and how they've been impacted by the pandemic. The Center for Community Solutions is a nonprofit, nonpartisan organization that focuses on health and human service, policy advocacy, and research across a variety of health and human service areas. One of them being Medicaid. So one of our staff members, Lauren Anthus, will be talking about Medicaid issues today in relation to COVID-19. And I just want to thank everyone so much for joining today. We're going to take questions in the chat box. So please, as those questions come up, please submit them in the chat box and we will try to get to as many as we can. I know in weeks past we have run out of time to answer all of the questions. So we're going to try to keep track of those that don't get answered and get those out to our presenters to get specific answers to anyone who has an outstanding question at the end of the webinar today. I'm going to turn it over to Kelsey Bergfeld now with Advocates for Ohio's Future to provide a little background about AOF and introduce our presenters. Thanks, Kelsey.
Great, thank you so much, Tara. As Tara said, my name is Kelsey Bergfeld and I lead Advocates for Ohio's Future. We are a nonprofit, nonpartisan coalition of over 500 state and local health and human service agencies that are all of our organizations work in policy, advocacy, and also providers of healthcare services. We strive to strengthen families and communities through public funding for health, human services, and early care and education. We really serve as the health and human service table of the state. And again, our primary purpose is to collaborate and work together on issues, to align on messaging and strategy with our elected officials at the state, local, and federal level, and also prioritize the needs of Ohioans, especially during this challenging time. I'm very excited to have a few of our AOF members here present today. They are, again, very valued members of AOF, and we are excited to have them with us. So three speakers today. The first will be Lauren Anthus. He is the Policy Fellow with the Center for Community Solutions. We have Steve Wagner, who also serves as co-chair of AOF. He is the Executive Director of the Universal Healthcare Action Network, or UCAN Ohio. And we also have Kelly Visro. She is the Senior Health Policy Associate with the Children's Defense Fund, Ohio. So Lauren, whenever you are ready, go ahead and kick us off.
Great. Thank you, Kelsey. Thank you, Tara. And thank you, Danny, for helping us today with the slides, and to my colleagues and acquaintances, Steve and Kelly, for joining today. I also want to thank every one of our attendees. I recognize a number of the names, so welcome. Hopefully you'll find today's session informative and you will tolerate my section. So let me start. We'll click ahead. That's me. If you need anything, if you have any questions or follow-up that you would like to go over with, if there's anything in this presentation you'd like to go over with me around, or if you have specific questions about some of the data, feel free to reach out to me. We also have a very timely and unannoying newsletter you can sign up for at communitysolutions.com. And if you like hot takes or just general good information, you can follow me and follow Community Solutions on Twitter. You can see the handles below. Go ahead. So let's start here. I first want to talk about what's happening with Medicaid as a responder in the context of public health, and as a responder in the context of public health and in terms of state finances. And I think the most relevant example we could probably borrow from is the recession. So during the recession, we saw a couple of things. Number one, we saw enrollment increase, and we also saw, due to stimulus funding, an enhanced FMAP, or the Enhanced Federal Medical Assistance percentage, of around 6.2%. In real terms, it was closer to 10% because of how many people were enrolling, and the decrease of state obligation to cover those expenses. Over the course of the enhanced FMAP, which did have an extension even beyond the initial term, we saw that there was a total value of about $3.4 billion between state fiscal years 2009 and 2010. What does this mean? So in 2008, the typical federal medical assistance percentage had a multiplier number of 1.55. So what does that mean? It means for every dollar that the state spent in the Medicaid program, it got back $1.55. In 2010, that number increased to 2.77. So for every dollar that Ohio put forward in state funding, it received back $2.77. So there was an immediate financial impact that bolstered the state budget while it was also covering more lives. We saw that unemployment over that time frame increase by 425,000. I think that might actually be 415,000, while enrollment in the program went up 370,000. And this is before Medicaid expansion, and this is before the passage of the Affordable Care Act coverage options here. So what we saw is what Medicaid has always been, which is a counter-cyclical program, one that not only injects federal resources into states, but also acts as a very important safety net. One thing that you need to sort of think about too is this has always been the case with Medicaid. So it's not just this last recession, but over about 5 recessionary periods since 1969 through 1999, and then subsequently the Great Recession, Medicaid and the funding associated with Medicaid has been responsible for protecting about 15 to 17% of our GDP, according to some economic forecasts. So the simple fact that the program exists and has the ability to inject these resources into states has a really important protective effect on state budgets and on state finances. So let's continue. The next slide. There we go. Okay. So where is this going to go? Well, according to some recent research, and you can find a link below, and we will make the slides available. I know that's always a question. The Health Management Associates did some predictive analysis about what is going to happen with coverage in the context of responding to COVID, economically and otherwise. And the thing that makes this particular recessionary period different than ones in the past is the fact that we have a marketplace and we have Medicaid expansion. But in their analysis, they essentially bring together different data elements, and they provide a spectrum of what's the potential. And it's a balance of not only the unemployment rate, but also Medicaid, the marketplace, employer-sponsored insurance, and uninsured levels. The estimates in unemployment range from about 10 to 25%. Okay, the Great Depression, I think, was around 25% peak unemployment. So what we're talking about here is the potentiality of what we could see in an unemployment. And in a Medicaid perspective, this would be about 425 to 953,000 additional lives that would be covered over the next few years. If you look at this report, what they expect is actually the uninsured or the number of individuals who would lose their source of coverage would be about 1.7 million at a ceiling. So we're talking about Medicaid essentially covering at least half of those folks, and the marketplace playing a key role in covering additional lives. So things to think about: the importance of expansion, because without expansion, these numbers significantly go down. And we're also talking about expansion in the context of its high federal matching rate. So we're talking about a program that's very economically efficient from the standpoint of state budgets. And then also national and state policy choices regarding eligibility determinations. So I would suggest that in a time of high unemployment, if you have work requirements, for example, that the only thing you're going to see realistically is disenrollment, right? And you're going to see drastic shifts in the risk pool relative to the program, but also employer-sponsored insurance. Let's continue. So there we go. Okay, so let's talk about what's happened so far. In the CARES Act, they did enhance the FMAP rate to 6.2%. The Center on Budget predicted this was about $1.2 billion a year which I think is relatively accurate. I think it's probably going to be a little bit bigger than that. But it not only increased FMAP, but had a maintenance of effort provision. So essentially mirrored what we saw during the stimulus funds. There was also other policies around delaying the DSH cuts, the disproportionate share hospital cuts in fiscal year 20 and 21. There was $250 million for community behavioral health centers, $1.32 billion for federally qualified health centers. And there was an extension of money follows the person, which is a popular community-based health initiative to try to deinstitutionalize care for the long-term care population. We saw in subsequent efforts through COVID-related legislation that the MOE provision be removed. I'll touch on this a little bit later before I end, but both pieces are pretty key when it comes to understanding what Medicaid can do from a coverage and financial standpoint. Let's go ahead and move to the next slide. One thing that we saw recently is the state thankfully created a Medicaid policy page. So that's where you can find it on medicaid.ohio.gov. It gives you important information about all the regulatory developments of the state, from telehealth to the 1135 waiver to the Appendix K waiver. I just want to touch on these things just a little bit. First of all, telehealth was broadly expanded. And this is something I think a lot of folks here know, but the services that you are able to bill for in the context of a telehealth appointment, both synchronously, live, or asynchronously, not live, was broadly expanded, and billing guidance was put out and is continued to be put out. I think it's really important too for anyone who works in behavioral health that they understand that the behavioral health components of this were expanded as well, and to be on the lookout for any opportunities for grant funding to build out capacity. One thing about the behavioral health network, especially the community behavioral health network in Ohio, is that unlike, say, hospitals or other institutions, they have historically been left out of high-tech dollars or EHR dollars, graduate medical education dollars, and other things. So there are resources now to help institutions in the community level build out their capacity with IT, build out their capacity with staff. So be on the lookout. An 1135 waiver. These waivers are enabled when the president declares a national emergency through the Stafford Act. Ohio is the last state in the country to be approved for its waiver. We also saw efforts from trade associations, successful ones, to promote their own 1135 waivers, which is unique to 1135 waivers. So the Hospital Association put one forward. I believe the nursing facilities, the Ohio Healthcare Association did as well. And essentially what they do is they provide some flexibilities in terms of where you can deliver service, how you can deliver service, licensure renewal, eligibility relaxation, prior authorization removal, cost sharing elimination, other things that just essentially make it easier to stay enrolled, to get services, and to maintain eligibility and receive payment. When it comes to the approval of this waiver, which happened, at least I saw something live on the 22nd, so Wednesday night, you'll see in the approval letter, it's very limited relative to what the state submitted. The reason for that is because, and this is something I'm still trying to understand myself, a lot of the pieces related to the application are technically changes that have to happen through Ohio's state plan, which is the contract that exists between the state and the federal government, for lack of a better term. So that requires state plan amendment submissions and requires the state plan amendment approval process. So we'll be on the lookout for those state plan amendments, but you'll notice in the approval level from the federal government, there aren't pieces relative to cost sharing or the suspension of redeterminations or paying for alternative sites for treatment for the homeless in places like hotels. That just may be a matter of technicality. It may not be a reduction by the federal government. So we'll have to continue to pay attention to those issues. Similarly, Ohio submitted an application, received some approvals for an Appendix K amendment to their 1915 waivers. So that sounds very nerdy, and it is. But long story short, is that home and community-based services provided to developmentally disabled individuals or individuals who are in long-term care institutions, so the aging population, the aging and disability waivers, there are lots of flexibilities granted in there as well, or sought in there as well, including things like allowing family caregivers with the appropriate certifications, which are lowered, to be able to directly receive reimbursement for taking care of family members. The idea being essentially that by doing so, you limit spread because you're limiting the potential for healthcare workers and others to act as vectors and spread the disease for a high-risk population. So lots of pieces in there, including benefit increases and the like. And if you're interested in any of these pieces, I would ask you to check out the website, or of course, you can always reach out to me directly. Next slide, please. So I just want to highlight what some of the things that were mentioned here. 1135 waiver, redetermination suspended, licensure renewals basically relaxed, additional telehealth capacity in addition to what the state changed through emergency rooms, the elimination of copays, waiver of prior authorizations, alternative site designation, which basically means people can be treated in places like conference centers and the providers can still collect reimbursement. And then verbal authorization and self-attestation, basically that you promise if you're enrolling in the program that what you're saying is true, as opposed to having to fill out a signature or go through additional paperwork. In Appendix K, like I mentioned, this is covering both disabilities and aging. The family provider reimbursement piece we touched on. Also telephonic service planning. So a big part of waivers involves planning out the services that you're going to receive. Now a lot of these can be done over the telephone. That's a new thing. And then telehealth, speaking of the telephone, an expansion of services. It includes new and existing patients. So that helps, sort of open the doors to prevent people to be required to enter into a relationship with a provider before receiving the ability to get telehealth services. The next slide, please. This is my last slide. Okay, so what else can be done? Number one, the National Governors Association put out a request of 12% for FMAP, and that it should not cease until unemployment falls below 5%. I've done some initial calculations here. What we're talking about is on the order of an additional $2 to $3 billion for the state of Ohio per year. Here's why this matters. Like I mentioned before, Medicaid is a counter-cyclical program, which means we're going to be spending more money as people enroll. And that's going to create pressure on the state budget in terms of what services are covered, the payment rates for those services, and how we're able to address the need as people get sick or they have to, suspend services in other areas. I think what's unique about this particular request relative to recessions past is the fact that our hospitals and our providers are significantly financially challenged by the circumstances that COVID presents, where they were able to still provide elective surgeries, carry out about their business, and really it's just a matter of source of coverage and rates associated with that coverage. The entire business model is disrupted. And so if the state of Ohio is to play a role here, not only would these increase in dollars ensure that there's enough funding and resources to provide some stability for providers, but also ensure that the coverage is adequate. It would decrease pressure on the state budget because the state resources wouldn't be as needed, whereas they would be more needed if you didn't have this additional support. And here's something that I think is really important, and I would like anybody who has relationships with folks who are concerned about the employer-sponsored insurance effects that COVID may have. There are some estimates out there. Cover California did a research paper that says that insurance premiums in the private market may increase or spike by as much as 40% next year. Medicaid historically has a deflationary impact on private premiums. In states that have expanded Medicaid versus those that did not, even over time, we saw that the average employer-sponsored insurance premium, the private market premiums, were lower compared to states that did not expand. So what this can do, and what the maintenance of effort can do, is it can allow a coverage option for more people as they are trying to re-enter the workforce, or they get laid off, or they're furloughed, et cetera, that also ensures that they can get services, right? And so that we don't see these premium spikes down the road. It does mean that maintenance of effort has to be maintained. And I think we're going to see this maintenance of effort question come up again and again, but you can't have one without the other. You need the FMAP, you need the maintenance of effort, which is basically saying that the state, in order to accept the federal dollars, is going to keep things and the benefits and the access to coverage the same. Also, I don't know who saw Senator Lehner's proposal. I'm sure Kelly will cover this, but increasing the eligibility for CHIP kits to 300% is a great idea. According to some of the estimates we have, there's about 446,000 kids between 200 and 300% of the federal poverty level. So we're talking about 500,000 children that would benefit from that policy alone. Medicaid can play a role, and there are different options, and we're going to be doing some research about what other options might be available for Medicaid to act as a coverage source during the emergency. Also, special enrollment periods. Ohio has a hybrid marketplace, but it's largely federal. So we don't have a special enrollment period for the marketplace without the federal government acting. So that means if an individual wanted to get coverage right now, they could not technically claim COVID as the reason. Now, there could be other reasons like they lost a job, et cetera, but a special enrollment period would certainly help. And then I think it would be smart to suspend the work requirement waiver. Right now, I just don't know how we could expect a population to engage in work activities when there's still an active stay-at-home order, or there are still limitations in terms of what work opportunities are available. And it's particularly dangerous if only because we're talking about low-income folks. So the types of opportunities we're talking about are likely not going to be ones where you can work from home over a laptop. So it's a significant potential risk. So we would ask anyone here to talk to their members of Congress, to think about this and to advocate for that 12%, advocate for the maintenance of MOE, and consider enhancing the coverage through Medicaid to provide us with some stability, as we know we have had before in 6 previous recessions. With that, we can go to the last slide. I'm more than happy to answer any questions, but I imagine, Danny, are we holding questions till the end, or do we do it section by section?
We're going to hold questions until the end just to make sure everyone can get through their presentations.
Great. Thank you, everyone, and I'll turn it over to Steve.
We're going to talk a little bit about how to get healthcare when you don't have it. UK and Ohio is a consumer-centered, and so we try and bring consumer voice to policy decisions and decision makers. Next slide, please. Lauren's talked a little bit about this problem, but uninsured rate we're one of the few whose uninsured rate climbed in 2018, the last time we had census data for that. This is an idea about how many people were lacking in insurance. So about 744,000 uninsured within Ohio in 2018 for the census. And then, of course, no surprise, but that uninsured rate is differential according to your race. So while only 5.4% of white non-Hispanics were uninsured, as many as 9.7% of Blacks, 17.8% of Hispanics were uninsured. Next slide, please. So Lauren laid out some of this as well. As of Saturday, the 18th of April, 855,000 Ohio workers had filed claims. That's 15% of the state filing claims, of the state's workforce filing unemployment claims. And unfortunately, health insurance is often tied to your employment status, or sometimes your lack of health insurance is tied to your lack of employment status. Next slide, please. So if you don't have health care, how do you get there? There's a handful of paths to try and get there. If you had, next slide, please. If you had insurance coverage through your employer, but you've lost your employment, there's what's called COBRA, and that's the Consolidated Omnibus Budget Reconciliation Act. everybody calls it COBRA. Employers with 20 or more employees, excuse me, must offer to continue the employee's insurance coverage for at least 18 months. The challenge with that, though, is that the enrollees must actually pay up to 102% of the full cost of that coverage. So they make the payment, and it covers actually some of the administrative costs to the employer, and that's why it can go up to 102%. And given that an employee-based health plan might be a fairly generous one, the cost on that can be pretty high. And then the other piece of that is that COBRA oftentimes is not available within small employers. It's possible that that your employer, if it's small, may actually have its own policy, which is COBRA-like, in that they'll help to extend that healthcare coverage, but it's not required that they do so. Next slide, please. So if you didn't have, or if you lost your insurance and COBRA is not the way to go, it's might be about getting the marketplace coverage. Some people refer to it as Obamacare, the ACA coverage. It is important to check first to see if you qualify for Medicaid. Okay, so especially in Ohio, where expansion has increased the income that you can have and be eligible for Medicaid, make that check first. Just so you know, the slides that I have the links to all of this. So if you're trying to identify where people should be sent, you'll be able to go through there. And then there is assistance then. If you don't qualify for Medicaid and people want to go through the marketplace, they can go there. You can do it all online. There is actually local help that is available through insurance brokers that help to do that. There are some navigators left in Ohio. So there's a particular navigator that serves a handful of counties, and those are identified on the slide. And you'll find that if you go to the local help that's available, there's an online link to find local help, and they can walk you through it. They can actually even do online assistance and work through the application with you and help to do that kind of remote guidance. Next slide, please. So there's still some challenges that could be addressed within the marketplace and how that's working. So yes, there is what's called a special enrollment period, SEP. So if you've lost your employment, you've lost your insurance because of employment, that is a qualifying condition that allows you to enroll in the marketplace. Unfortunately, the documentation that you have to provide for that can sometimes be a little challenging to get up there and posted. And so that SEP can be a little bit challenging for people to get enrolled in the marketplace. Other states have fully opened up an SEP for all who are uninsured who would like to get into the marketplace right now. So those who operate their own marketplace, like Washington, Oregon, California, have opened that fully up. If Ohio had CMS do that for Ohio, we could see as many as 132,000 people able to enroll in the marketplace. And that's not just important for people that are uninsured who didn't meet this SEP. It's also important because they can change the standards and the documentation that you have to provide to make it easier for people to enroll in the marketplace at this point in time, which is mid-period of the insurance. Next slide, please. The other piece is that the special enrollment period should be advertised for making people aware of that. That option is available. So ODI could certainly help with making that available. The 2 o'clock briefings that everybody watches, making some statement about the fact that there is that special enrollment period that's available. Bullet number 2 is suggesting that CMS should open up a special enrollment period for Ohio that would allow all uninsured to apply for marketplace coverage. There is already no cost sharing for screening for COVID, but the challenge is that COVID treatment can have some substantial cost sharing with it. That would be an improvement that could occur through marketplace plans. It could certainly happen in the future year of the marketplace plans as well. And then one thing that ODI has already done that applies within the marketplace plans is that there's an assurance of 60-day continuation of coverage. So even if individuals are having problems paying their premiums, there's 60 days people have of grace to catch up on those payments. It doesn't waive their payments, but it does provide people some time to be able to make their premium payments. Next slide, please. The other thing is, we're getting to the point where the insurance companies will be providing what they think their rates are for the marketplace plans this next time period. You've heard already from Lauren that there's some expectation that those rates may be going up. If for no other reason, then you'll remember when there was so much discussion and uncertainty about what would happen with the marketplace because of Congress's potential actions. Insurers don't do well with uncertainty. And so there's a great deal of uncertainty about who's going to want to be insured next year, what kind of vulnerability they have with their health conditions, are all sorts of things that may cause the premium cost to go up next year. The Ohio Department of Insurance has a responsibility to review those rates and consider whether they are appropriate, and they have some authority to make sure that those are no higher than they should be. And some of the factors they can consider are the types of benefits that are there, the enrollee risk profile, what kind of reserves the insurance companies have. So ODI really needs to pay close attention to what those rates are that are being submitted and do a really very careful review to ensure that those rates go down, don't go up any higher than they should. The other thing to know is even when rates do go up, there is the benchmark plan, and that's the second highest, the second lowest silver plan. The other piece of this is that in Ohio, what we do is called silver loading. Because the feds are no longer paying the other portion that they should be on the cost sharing, all of those costs get loaded into what the premium rate is. And therefore, even if they did say that, for example, COVID treatment had no cost sharing, that cost would then be loaded into the premium cost and would be part of whatever that benchmark plan is ostensibly. So the help with the plan that people can sometimes qualify, that subsidy, should also be fairly rich then, so that hopefully people will be able to afford that premium. So we'll see how that plays out. Another thing that could happen would be that through Congress and the president, they could look to change the cap on the premium. So right now there's a cap as a percentage of the income that people have to pay for a marketplace premium. They could change that cap, and that would effectively lower most people's expenses with regard to the premiums. Next slide, please. So uninsured, also unacceptable. So I think state of Ohio and CMS need to figure out how we're going to get people insured. So one of the things that was mentioned on the previous slide was emergency Medicaid. So emergency Medicaid is a way of being able to reimburse providers for individuals who are uninsured, and it is generally used for those individuals that are not U.S. citizens and under a particular immigration status. That provides the ability for emergency treatment, such as treatment for COVID, to be billed to Medicaid, and then the same kind of cost sharing occurs. It does not impact on MOE. In other words, they do not become Medicaid recipients. It's simply a way to bill, and the state and the feds pick up a share. I mention it in a sense in passing because in the past day and a half, HRSA released guidance which allows for payment to providers through funds that became available in the Families First Coronavirus Act. And that was about $1 billion to reimburse providers, plus another $100 billion in relief funds that, to hospitals and healthcare providers. And that's going through, and it really is, again, about insurers basically saying, providers saying, I have a patient that's uninsured, I've ascertained that, and I would like to reimburse for COVID-related expenses. So there's, that includes not just specimen testing, it also includes treatment, office visits, it includes skilled nursing facility or long-term care, even ambulance, FDA, and drugs. So there is now some ability for COVID patients that are uninsured for their bills to be paid for under Medicare rates. So it'd be paid to the provider. The provider is just going to bill Medicare, but the provider also has to guarantee there's no balance billing of the patient. So that's good news. Providers should take that up. Patients should, if they're in hospital, if they need care for COVID, they need to bring that up with their providers. Next slide, please. My contact information there. There'll be a number of subsequent slides in this presentation that also provide some resources about where people can find healthcare. And so I'll conclude and turn it over to Kelly.
Thanks, Steve. I think I need to up my PowerPoint game. I have no pictures of myself in any part of my PowerPoint today, so use your imaginations. I'm lovely. I'm going to talk to you today about Medicaid and CHIP and how they protect Ohio's families and children during the COVID-19 pandemic. And you have my contact information there. So what are we looking at? We have schools and daycare centers closed, all non-essential businesses closed, stay-at-home orders for everyone who is non-essential. There have been, at the time that I made this, a couple days ago, this may have changed, over 13,000 confirmed cases of COVID in Ohio, and 557 people have died. Next slide, please. We are looking at a lot of unemployed families, and that means a lot of uninsured children. Over 964,000 Ohioans have filed for unemployment between March 14th and April 18th. Before the pandemic, we were looking at 8% of employed Ohioans did not have insurance. They were not insured through their own, through Medicaid, or through an employer-based insurance program. If you apply that number to these newly unemployed people, you could be looking at 70,000 newly unemployed who do not have health insurance coverage through their previous employer, and therefore are not eligible for health insurance through the marketplace. What we know about families is, or children and families, is that when a parent is insured, the children in that family are more likely to be insured. We also know that children exist in a bubble, and parents with insurance feel less stress in relation to taking care of their families. We have all heard stories about families experiencing one medical event that bankrupts them. And that causes a lot of stress and health issues, both physical, emotional, and mental within a family when you have that kind of stress. Parents with insurance are better able to take care of and raise healthy children. They're able to access behavioral and physical health care, as well as addiction services that would be out of reach for most families without insurance. Next slide, please. When we look at children, the Ohio landscape before COVID-19, in 2018, you had Ohio with a child uninsured rate that was 4.8%. That was up a full percentage point from 2016 when the rate was 3.8. And we know that Ohio has one of the largest rates of decline in child health coverage in the nation. In 2019 alone, more than 23,000 children lost Medicaid. Why is this happening? We're in the middle of studying this problem right now, but there are probably many answers as to why this is happening. It could be the dismantling of the Affordable Care Act and navigator services that help people find insurance. It could be an issue that the parents aren't aware that their child can have access to Medicaid and CHIP, and that their eligibility level is higher than the parents. So even if a parent doesn't qualify for Medicaid, their children may. So, you know, if a parent lost their Medicaid, they may think that their children are no longer covered either. So those are all issues that we're looking into right now. But you can see the areas of Ohio, when you increase the size of them. The magenta color are counties in Ohio that had rates of decline of 2% or more. The purple counties are counties that had declines of between 1 and 2%, and then your teal colored counties experienced less than 1% decline in insurance. So, you know, you can see that a great majority of those states are looking at rates of decline of more than 3%. Next slide, please. In Ohio, over 1 million children are covered by Medicaid. Within that Medicaid program, there is a health check program, and that's your EPS DT, your early and periodic screening, diagnosis, and testing program. And children are entitled to all of those services on the left-hand side with the check marks next to them. And this includes 12 visits for the first 2.5 years with developmental checks and immunizations. And this is specific, this is really important this is something that we'll talk about in a couple slides, but it's really important that these young children take advantage of, the parents of young children take advantage of these services, because having those children vaccinated early and having those developmental checks is really important to their future health and their health into adulthood, to be honest. The next slide, please. So a few weeks ago, we worked with Senator Lehner and Representative Rousseau. They wrote a wonderful op-ed piece that was published in the Columbus Dispatch last week. And we came up with some recommendations. And the first one was to prioritize childhood immunization. And we put this first because it's something that can be done without legislation. It's an easy lift. All it requires is that the governor and health professionals, including pediatricians, talk directly to parents and caregivers, ensure the safety of having their children immunized, and stress the importance of doing this as a way of managing public health. What you don't want is a vaccination gap, and that's what we're afraid we're going to start to see here soon, because parents are afraid to take their children out of the house to a pediatrician's office, if that office would even be open, or there would be appointments available, because they're afraid of exposing them to COVID. So they may be putting off those childhood immunizations You could see a rise in mumps, measles, pertussis, diphtheria, those kind of things, which really do threaten the children that are not immunized. They threaten children that have health conditions where they're immunocompromised, and also adults that can't be immunized because of health conditions. And it does really threaten an entire community when you start to see those things happen. You know, we were also asking for to expand presumptive eligibility, to increase the CHIP to 300%, which I know Lauren and Steve both talked about, temporarily suspending Medicaid redetermination, re-enrollment, and terminations to allow people to come onto the Medicaid program with as little fuss as we can manage through the end of this public health crisis. You know, accept the enhanced FMAP of 12%, suspend public charge. And this is really important because this addresses the immigrant and new American population in Ohio who are afraid to access healthcare because they're afraid that they're going to come into someone's, someone's going to notice them. They're going to come under a public charge, or you know, they're going to be separated as a family. And also to reopen the federal health insurance marketplace. Ohio does run theirs as part of the federal system. There are only 13 states that have their own marketplace. We're not one of them. So it would be really helpful for families for them to open that marketplace back up and allow these newly unemployed families to access that benefit. Next slide, please. What has been done so far? So I know Lauren covered the Families First Coronavirus Relief Act, and it does some of the things that we were asking for, including, you know, enhancing the federal match, the testing of COVID patients being covered by Medicaid and CHIP without cost sharing, and then not disenroll, you know, requiring Ohio to not disenroll anyone who is currently on Medicaid or who had become eligible for Medicaid during the state of emergency. And the next slide, please. Ohio also filed an 1135 emergency waiver, and that what they asked within that waiver was to expand presumptive eligibility decisions to include hospitals and Department of Medicaid staff, suspend eligibility renewals and terminations within the Medicaid program. From what I understand, CMS released some of the items they approved in Ohio's 1135 waiver request. However, these items listed here, we will see answered in the SPA request, which I do not believe has been released yet. So we're still waiting to see if these types of items that were in the 1135 will be approved. And the next slide, please. So what are we still looking at? What do we need to do to fill the gap? We need to prioritize childhood immunizations, increase the CHIP to 300%, open federal insurance marketplaces, and suspend public charge. 8% of all children in Ohio live with parents who are immigrants to this country. That's over 211,000 children in 2016. And it's important that issues like public charge and fear in general don't prevent them from seeking health care that they need. There's a great deal of fear felt by Ohio's immigrant community, and it's not unfounded. Ohio has a smaller immigrant population compared to other states, but it has experienced the third highest rate of ICE arrests in the country, right behind Pennsylvania and Michigan. These are adverse and aggressive actions towards this immigrant community, and they take place at an individual's home or at their workplace, and it creates a great deal of fear within that community, extending to individuals who are in the U.S. with documentation and children within those families that are U.S. citizens, maybe living in mixed status families. So, you know, I don't think that anyone wants an entire community of people not seeking health care during a public health emergency and continuing to, suffer the effects of this virus, or, spreading the virus because they're afraid to access health care. So we need to reach out and help these families, and suspending this public charge would go a long way to doing that. Next slide, please. That is all I have. My contact information was on the very first slide, so when those go out, if anyone has any questions, please feel free to reach out. Thank you very much.
Great, thank you again to all of our presenters. I'm Danny Carlson, I'm our Communications Director. I did want to apologize, we had a technical issue at the beginning which wasn't allowing all the participants who signed up to participate in the webinar, so I will also follow up with an email, but a recording of this will be available, as will all of the slides later today on Community Solutions website. Now, we did have a couple of questions, and if you have any more for our presenters, please put them into the chat box. The first question, I think, could go to any of the presenters. Has the staff been increased to meet the demand? This person says she knows a young person who no longer is working and has no insurance, and she's wondering how difficult it's going to be for that person to get Medicaid. So has the Medicaid staff increased to meet the demand?
I'll take that to start at least. I know when it comes to eligibility processing, if that's the question that we're talking about here, that additional staff had been provided to Job and Family Service departments. I know that, on the background of things, they're very concentrated on these issues as the state. But this is also why the state plan amendment pieces around suspension of redeterminations is important. It's also important why we have things like self-attestation, because the easier you make it for people to enroll and the less hands-on they have to be, the more likely they are to get coverage simply. It's also important to realize too that federally qualified health centers and hospitals retain their presumptive eligibility and retroactive eligibility abilities, for lack of a better word, which means if you run into a problem, if you have a healthcare issue and you go to a hospital and you're low income or you just lost your job, you still will have many of those services, if you're eligible, covered by the Medicaid program. So I would say, there's a lot of pieces here that are operating, but yes, the state has tried to dedicate some resources, and we'll see if some of the other policy pieces around eligibility are refined. I don't know, Kelly or Steve, if you have any more insight.
I do not.
Okay, moving on to the next question. It was addressed to Lauren, but if either of the other panelists also feel able to answer it, please feel free. If our organization's goal is to expand healthcare access, what, if any, of these rapid policy changes, e.g. self-attestation, would we want to protect beyond the pandemic? And are there things we should be doing now, for example, collecting data on fraud or lack thereof, to prepare for policy discussions in the not too distant future?
Yeah, and I think Kelly spoke to this a little bit. I know we're looking at this, CDF is looking at this, but we're looking at this as Community Solutions across the board, trying to understand what's been going on with the Medicaid eligibility system, especially in regards to kids. There are a lot of policies here, whether we're talking about telehealth or the relaxation of licensure or whatever, that are worthwhile understanding after this all sort of gets resolved. When it comes to things like fraud, one of the things that we highlighted was, well, first of all, I want to mention that, fraud and waste doesn't really happen on the consumer level. It happens on the provider level, typically. And even then it's very minuscule or minute. It's sort of one-off. But we, stated that the federal government should try to protect states as they change these systems, so that if mistakes are made, or there are challenges with applications, or maybe people enrolled who quote unquote shouldn't be enrolled or weren't typically eligible, that we sort of relax those pieces. And we've seen that sort of authority granted in other states. But I think, yes, Dan, your point is well taken, and we're definitely in the process of data collection around that. I don't know, Kelly, if you want to talk at all about your efforts.
Yeah, I mean, I think any of the, I think we would love to see the public charge thing disappear completely. I don't think that's anything on a federal level that's actually going to happen, at least not during this administration. Things on a state level, I think the easier you make it for families to get health coverage, the better. So, I like that we have the 12-month, kind of rolling redetermination, and that kind of thing is good. So any of those types of loosening of rules is great, because the more families you get insured, the more children you're going to have insured. Even, expanding presumptive eligibility is a great idea. It just allows more people to help, to get these families enrolled. So yeah, I mean, the expansion of to 300% for children, great idea. I'd love to see that stick around. If they would, eventually do that, would love to see that stick around as well.
Steve, not sure if you had anything to add to that. Just want to make sure everyone has a chance.
I appreciate that. No, I don't think there's anything to add. Thanks.
And then we did get another question in. A family that someone is working with, the mom was laid off, has no insurance. She and her husband have 2 adopted children. The children have Medicaid. The parents applied for Medicaid, but they were denied coverage because the dad makes $12.75 an hour, and adoption subsidies for the children is counted in their income. The mom is in need of insulin. What is an option for her/them in regards to insurance?
Yeah, I think they need to pursue marketplace coverage then. If they're not making Medicaid, marketplace coverage might be affordable for them, because it sounds like they're super close to the line, and the amount of subsidy that they would get should be substantial. So I think it's about applying there and seeing what kind of plan. And I would suggest they try and contact an in-person, so either a certified application counselor through that local help, or a navigator.
And kind of a follow-up question to that, how does anyone plan to get the information out to assist the community in understanding the changes via Medicaid or the marketplace? This person's asking if there will be a visual campaign to encourage the community to be proactive to get insurance.
Yeah, I guess I'd say that, that's where our reach has kind of been limited. We have put out that information, but we don't get everything out there. I think, the most effective piece right now would be if there was even just mention within the governor's briefing, or if there was better identification of that within the aid to families that's part of the COVID site. So we have encouraged that, but I just haven't seen that yet.
Yeah, and this also underscores the challenge that we face as a state, where the federal funding for navigators was cut by 90%. So where there was help a couple of years ago, that no longer exists. And beyond that, other states have made the very intentional effort to create consumer outreach programs, state-run, user-friendly websites that have been shown to increase coverage options, not only in Medicaid, but in the private marketplace and in the ACA marketplace. And Ohio hasn't done that. So I think part of it would be just to share the information where you can, and ask your policymakers to promote it. And in terms of a policy idea, do more to promote coverage, finance, coverage navigation directly by the state, or ask the federal government to restore the funding that used to exist at places like food banks, where this would be a particularly useful and captive audience.
Great, thank you. And we do want to be mindful of everyone's time. We are at that 2 o'clock mark. So thank you again to all of our presenters today for an informative hour with you. As I mentioned before, a recording of this webinar and also the slides will be available shortly today on Community Solutions website. And be sure to check back. We will have another webinar in our Friday webinar series next Friday as well. So be sure to check that out as well. Thank you very much for your time today, and stay safe.